This non-promotional podcast series is organised and funded by UCB, intended for healthcare professionals in the UK and Ireland.
Welcome to the Let's Talk About Dravet Syndrome podcast series. I'm your host, Micheal Taylor. I'm a consultant paediatric neurologist in Leeds Children's Hospital. In this series, we'll share practical input from specialists and real-life stories from patients and their families. This is to bring you closer to this topic, raise awareness, and empower the medical community to work closely with patients and their families to improve outcomes and quality of life. If you've not done so, please hit the subscribe button so you don't miss another episode. And if you love this podcast series, please do me a favor, give us a rating or review on whatever platform you're listening to us on. The reason we need this is the more positive reviews or ratings we get on those platforms, the more this podcast will be shown to those who have never listened to us before. The aim is to improve the lives of people who have Dravet syndrome. Today, we're going to talk about neurodevelopment in Dravet syndrome. As you might recall, in the first episode, we talked about how the patients with Dravet syndrome are typically neurodevelopmentally normal prior to presenting. Now, that's not true for every single patient. And if you look at the studies, it probably is true for about 98%, with 2% having some developmental issues prior to seizure onset. That tends to be common in those patients who have truncating mutations, and they tend to present with more severe intellectual disability, round about that 2 to 6 month period. For the most part, patients have significantly adverse neurodevelopment, with severe intellectual disability occurring in around 50% of patients, and moderate intellectual disability in 25%. There is a cohort of patients who will have borderline IQ, meaning that they're developmentally not too bad, and that seems to be around 6%, and that's been replicated in several studies, both in Sweden and in Australia. We know that most patients will be ambulant, so they'll walk. And that's true in about 99% of patients. In teenage years, we know that a lot of patients enter into what we call crouch. So they walk in a very different type of gait or different way where they sort of flex at their knee and hip. There is always the risk of language skills being poor or non-existent, and but about 97% of patients, depending on which trial you read, will have some form of language skills. There's always a debate about the patient who has a normal IQ and who has Dravet syndrome. That generally results in a lot of discussion, and again, seems to be replicated in studies, depending on where you read. It's very interesting because I've seen of some of the world's greatest Dravetologists have very different opinions on can you deliver a diagnosis of Dravet syndrome to somebody who has a normal IQ? Is it not just genetic epilepsy, febrile seizure plus? I think that's one of those things that we're going to capture with time. In the UK, we're running the SCM1A Horizon study, which will hopefully help us capture these patients and understand more about the developmental trajectory as we undertake neuropsychology as part of the trial. Developmental impact is a key diagnostic aspect of Dravet syndrome. When it comes down to it, at the core of this is a family and a child. A family who have a normal baby. A baby who has now developed significant seizures. And more importantly, who are being told that their child is going to have difficult to control seizures that potentially are life-threatening and who will have a significant impact on their development. Developmental slowing may not be apparent even outside of that first year. Professor Ingrid Scheffer, one of the world's greatest living dramatologists, undertook studies detailing her absolutely massive cohort in Australia. And the average age of developmental slowing was at 20 months, with a range from 3 months to 5 years. Contrary to the typical data that we have had, Professor Sheffer's study found that around 25% showed slowing within the first year of life, which is much earlier than we'd usually think about. It also showed that the very mild end of the neurodevelopmental spectrum, definitive slowing, was not seen until 5 years of age. From a clinical perspective, I've had patients who it's been really difficult to discern, are they a very mild learning difficulty, which would make them a Dravet syndrome, or are they intellectually normal, albeit with a slightly lower end IQ, who have genetic epilepsy, febrile seizure plus. And it really has been observing, taking clinical history, and utilizing neuropsychological resources and working with my colleagues to try and really pick out those very subtle issues. We also have to address some of the comorbidities that come with it, namely autism spectrum condition, which is present in around 40% of patients. Having a bespoke Dravet clinic, it is frustrating to have the number of families who come into me saying, our local team will not give us a diagnosis of autism because they're saying everything is down to Dravet syndrome. It's really important for anybody who looks after the development of any child with Dravet syndrome to realize that autism is a recognized part of Dravet syndrome, much like the seizures. It is part and parcel of their diagnosis, and the children should be given the diagnosis if they meet criteria. It should not be held off, and it shouldn't be delayed. Again, the same with attention deficit hyperactivity disorder. Many of my patients have an ADHD phenotype, but are unable to access their services or are being denied their diagnosis. So I think it's really important that we, as pediatric neurologists and epileptologists who treat children with Dravet syndrome, advocate that they are allowed to avail of the other diagnoses and pathways. And more importantly, the families should be empowered to challenge this at any time and look for support from their multidisciplinary team. But why is development important to talk about in the context of the medications we treat? We don't know if we treat aggressively or if we get an early diagnosis will impact development, because we know that these are developmental and epileptic encephalopathies. Yes, we know that severe epilepsy will have a developmental impact, but what we also know with Dravet syndrome is that it is not just down to the epileptic burden, and it's part of the underlying gene mutation. Why is that really important to understand? Well, it gives us a further push to consider our treatments. What's really exciting, as I've previously mentioned in the first episode, is that we're moving towards gene therapy. And some interim analyses from Dr. Sullivan show that there are small improvements in communication skills, along with stability and other developmental aspects. So we're looking at treatments that are going down to a molecular level, potentially going to have this profound impact on how these children engage with the world. The next thing we need to mention is school and educational provision. Some children on the milder end will end up in a mainstream educational environment where Dravet syndrome is not something they've routinely encountered or ever encountered. So it's really important that we educate teachers and give them confidence in managing both the neurodevelopmental aspect as well as the seizures. Our special educational provisions will be much more attuned to children with complex epilepsy, but they may need some guidance about children who specifically have Dravet syndrome and may need to understand about the range of intellectual disability, the comorbidities such as autism or ADHD, or the issues with motor skills that may manifest in later years and may need physiotherapy input, potentially surgery, or if you look at some of the interesting trials coming out of Japan, it'll be interesting to see how that one bears out in years to come. It's a key aspect of many of these patients that their development is adversely affected by both the gene itself and the epilepsy. What can we do? At this time, the only thing we can truly modify is the epilepsy. So that's why early diagnosis, not going on to inappropriate drugs, and advancing the next stage of trials, especially with the antisense oligonucleotide trials, is going to be key. One of the major aspects to think about when it comes to any of the developmental and epileptic encephalopathies is the impact on parents and caregivers. In 2017, Vilas undertook a study of parents and caregivers of children with Dravet syndrome. 66% had depression, and only 26% had any form of family therapy, and 74% of parents reported having concerns on the emotional impact of siblings. And it wasn't just seizure control. It was behavior, communication with the family. It was a high proportion of the children were being slept with by their parents for fear of SUDEP, as we've mentioned in the last episode. We know that the impact on siblings of any child who has a significant developmental and epileptic encephalopathy is massive, and that was reflected by Bailey in 2020 through the Siblings Voice survey. And we know that anxiety is incredibly common. 35% of siblings in adulthood report a history of requiring treatment for clinical depression. So the development is not just affecting the development of the child, but is then affecting the development of the adult and subsequently their adult sibling. And subsequently that will have an impact on their children as well. So this diagnosis doesn't just hit one person, but reverberates back through the family and hits into the next generation as well. I have cases of families who we've been able to institute appropriate treatments, and actually they're able to go on holiday for the first time in 10, 15 years. Some families who are not originally from the UK have been able to go back to the country they originally came from for visits whenever they haven't been there in a quarter of a century due to multiple family members having Dravet syndrome. We know that there's a huge impact on a family from a financial perspective, with many parents having to come out of work or having to call in sick. That's going to have a repercussion on what the family can afford to do, on the opportunities made available to siblings or to the child themselves. So it's really important, again, that we treat the children appropriately, ensure that they get a robust diagnosis, such as a diagnosis of autism and ADHD, and avail of the appropriate therapies for those. And we ensure that there is support for the siblings and parents. That's where in the UK, we're very, very fortunate. We have Dravet UK, who have some fantastic literature available for siblings of all ages. If you don't have those, please make sure you contact Dravet UK or ask your pediatric neurologist. Some of us will have a few of these books sitting on our shelves. At the core of everything we do is a child But I hope that this episode has allowed you to think about the developmental impact in advocating for your patient or your loved one, making sure they get the right diagnosis, and more importantly, thinking about that family unit as a whole, understanding that the developmental impacts don't just hit that one child, who is an incredibly important individual, but hits the whole family, and there needs to be a holistic approach to how we consider this. Hopefully later in the series, we'll be able to get some family members in to talk through their experience of living with a loved one with Dravet syndrome.
Well, that's it for this episode. If you love this episode, please share it with your appropriate colleagues. The only way this podcast is going to get out there is by you lovely people sharing it. So I would appreciate it if you could. And if you want to stay with me and learn a little bit more about Dravet syndrome, then please join me on the next episode. For now, I'll say goodbye and see you next time.